So actually, if you call me Siraj, that's fine.
Okay.
But actually, right at the start, I think I'm going to start asking people to
Assalamu
tell.
alaikum. Welcome to day 2. Dr. Siraj, you can start now.
Assalamu alaikum. My name is Siraj. I'm one of the consultants here in internal medicine at King Abdulaziz Medical City in Riyadh. Now, to give you a little bit of an introduction about myself, I'm from the UK. I did my medical training in Oxford in the UK, and my specialty is a bit unique in the sense that whilst I'm working here in internal medicine, in the UK I trained in internal medicine and was a consultant in Oxford internal medicine, and then retrained in anesthesia and intensive care. So I have a broad range of specialties and have had insight into multiple care pathways of both acute and chronic care. So I've been involved in patients going from the front door, from the emergency department, all the way through the hospital to the intensive care, to the operating room, back to the floor, and then leaving the hospital. So I have a overview of the entire process of healthcare, which is what which is why I've been asked to talk to you today about medicine that's relevant to case management. So, inshallah, hopefully, over the next few hours, I'll impart some of my sort of thoughts about that. But essentially, what I would like it to be a bit interactive, if at all possible. So, if you send some questions, I'm very happy to take them, and I'll try and take them during the course of the lectures, so that it will break up the program and make things a little bit more interesting. So please feel free to ask questions, and if I haven't made things clear, then please do highlight that, and I can try and go over things in a different way. Okay. So the learning objectives for this first talk are to go through what doctors do. We're going to talk about the 2030 vision and the healthcare transformation strategy within that, which discusses some new models of care. They're not really new, they're just reworded, but the terminology is new models of care. Within that, we'll discuss the roles of case management, and we'll talk about health education and promotion, and some healthy and unhealthy behaviors. So that's the learning objectives for this first section of my presentation. But over to you now. So what do you think are the roles of doctors in patient care? So if you can actually just put in the chat some sort of concepts of actually what you believe doctors actually do. Now I'll switch over to the conversation and chat and see what sort of things people are thinking about. Does anyone have any ideas about what they feel that doctors do? Excellent. So someone said educate the patients. So that's certainly one part of our role is education. Anything else? Excellent. Set a care plan for the patient to be followed by the team. That's very, very important. So we, as doctors, we certainly do take an overview of the care plan, but we engage with multiple other specialties to try and get a holistic overview. Okay, those are very, very good ideas. So, and certainly diagnosis is actually key. So we actually have to find out what the problem is so that we can actually solve that. Before I tell you, actually give you an overview of what doctors do, I'm going to tell you a story. And I'm going to tell you a story about a Japanese actress. So this is a lady called Meiko Kawakami, and she was being interviewed on a talk show in Japan. And they were discussing her life, and she mentioned that she was very upset. So she just bought a dog, a specific type of dog, a poodle, and she thought it was sick. So this poodle, it was not barking, and it didn't want to eat. So, you know, what do you think was wrong with this lady's poodle? So if you can just put on the chat, what sort of things you think are wrong with this lady's poodle? So at the moment, we're trying to diagnose what the problem with the poodle is. It's you know, she just got it, and she's very upset because it's not eating and it's not barking. Does anyone have any ideas about, you know, how we can help this lady and her poodle? Okay, so we have some ideas coming through here, but basically, this is her poodle. So what's wrong with her poodle? It's actually a sheep. Now the issue is that I guess in Japan, they'd read about poodles, they wanted to get poodles, but actually they'd never actually seen someone before. So what happened is some very sort of cunning Australians were selling them sheep shaped to look like poodles, so that you know, they could make some money. Now, you know, the Japanese people, because they'd never seen a poodle before, they just thought, okay, you know, this is what a poodle is. So the sort of moral of this story is that if you've never actually seen something before and you've only read about it, then someone can pull the wool over your eyes. So basically, for those of you who haven't seen poodles and sheep before, I'm just highlighting that, you know, this is actually what a poodle looks like. This is a sheep that's been shaped to look like a poodle. This is another picture of a poodle, and this is a man in a sheep suit. Okay, so the Saudi sort of equivalent of that concept is this proverb. Now I'll give you a moment to think about that, but essentially the relevance of this to medicine is that if you only, and case management, is if you only read and you don't actually see patients, then you actually are going to miss many things. So we have to read, we have to learn, but we also have to apply that knowledge and and otherwise, and we also have to have some training, as exemplified by this gentleman, who was reading books, studying hard, and training and gaining experience to get his superpowers, and as did this gentleman. Now, this gentleman is one of the sort of forefathers of medicine. He was at the end of his career a professor in Oxford, and he trained people who then subsequently trained me in Oxford, and he was a very, very astute clinician. And he actually said that if you study medicine without books, it's like sailing in a sea you have no idea where to go. But if you study medicine without actually any experience, then it's like just reading books and not sailing at all. So the two need to go together. Now we come back to what actually doctors do in patient care. So I've got some pictures of peas here. There are 4 peas. They're sort of peas that you eat. And in a self-depreciating way, I'm going to summarize the entire 25 years of my medical experience, training, learning into 4 words that begin with the letter P. Okay? So, and then we'll go through those. And some of the people who've been sort of messaging in to say what we do have highlighted some of these things, but I'm going to cover them in a very quick, succinct way. So the first thing that we do is, I've called it prognostication. What that means is we assess patients' risk of having problems. So that's the first P. The second P is, once we've assessed the risk of having problems, we try and prevent those problems from occurring. So the next P is we make things possible. So what I mean to say is we enable things, we enable patients to do things that they wouldn't otherwise have been able to do if the disease wasn't treated. And the treatment that we give them, and I've called that a prescription. So we're going to go through those things in a little bit more detail now. So as I've said, prognostication, the risk assessment. So when patients come to hospital or are seen in a clinic, they're coming because they are generally unwell. And there is a range of things that they may have. But we don't know what they have until we do some tests and assessments. So we cannot test for everything, so we have to be selective. So when we're selective, we decide, okay, the risk of this problem is highest and the risk of this problem is lowest. But although the risk of this problem is low, if we miss this problem, then it can cause, the patient could die. So in this way, we think about the patient's issues and concerns and stratify them into priorities. Once we have got our priorities, we try to think about how we can actually prevent the patient from being harmed from these conditions. If a patient doesn't actually have a medical problem and we give them a tablet like aspirin to prevent them having heart problems, we call that primary prevention. What that means is the patient doesn't have a problem, we're going to try and stop it from happening. But let's say the patient already has a heart attack or has a stroke, they already have a problem, but we don't want them to have another problem or get a bigger problem. So we give them some other medications to stop that problem from getting worse. And we call that secondary prevention. The next thing that we do is if patients are unable to do something because of a disease, we organize some rehabilitation for them. Okay, so what that means is that they have a functional limitation. They can't do what they what they normally would be able to or would want to do. So I prefer to think of this in a different term, which I call enablement. So we try and enable people to do what they would like to do. And finally, prescription, simply treatment. So, and treatments are not just medications. They can be lifestyle changes. They can be advice about things people should do and they shouldn't do, and they can be sort of medical devices that will support the patient's organs to work better. So prescription covers a very, very broad range of things. So in summary, this is what I have spent 25 years doing, summarized into 4 words that begin with the letter P. Okay. Now, if anyone has any questions about that, then please send them in, and I can take those now, because really this is an overview of everything that we're going to be talking about for the rest of the day, and it's good if we actually get this clarified from the start. Okay, because the role of the doctor and nurses and all the other allied healthcare professionals and case management has been sort of reimagined in this document, which is the Vision 2030 Health Sector Transformation Strategy. Okay, so this document outlines the direction of healthcare for the next sort of 10 years in this kingdom, and it's highlighted several key areas of development, and it's brought in some terminology, and it's described this sort of healthcare model as a new model of care. Okay, so the next phase of our presentation is going to be sort of literally going through this document and considering the role of case management in this new model. It's not really a new model. It's an old model that has been rebadged and rebranded with specific focuses on areas of healthcare that are critically important, and also have until now been for some of them relatively neglected. Okay, so what are these new models of care? So the document says that this model should be taken as a focal point for enhancing personal value of healthcare within the kingdom. Okay, the model aims to improve treatment and care modalities, not at the organizational level, not at the level of the hospital, not at the level of the sort of healthcare networks, but specifically focusing at the level of the individual. So the new model of care is hoping to improve individual outcomes. Okay, and so it's conceptualizing a much more personal view of healthcare within Saudi Arabia. Okay, now there are basically 6 key phases of the new models of care that goes across the broad spectrum of healthcare provision, from the individual themselves through the sort of community, virtual care, primary care, general hospital care, and specialist hospital care. And the phases that the new model's focusing on are keeping me well. So stopping people from getting diseases. So this is the primary prevention that I was talking about previously. The next phase is urgent care. So this is this is treatment for any acute life or limb-threatening problems. Then we talk about chronic care. So chronic care is care for patients with chronic diseases that they are going to have over the course of their lifetime. So here we're talking about secondary prevention of complications. Planned care is care for patients who need surgery, essentially. So you have a problem that is not acute, but it needs to be dealt with within a specific time frame. You're given a date to come in to have an operation. This is planned. Okay. Women and children is related to childbirth and healthy childhood. And the last phase. And the last phase really is something that has been almost completely neglected within the kingdom. And this is the concept of palliative care, ensuring people have the care that they want in the last phase of their life. And even within our organization, the National Guard, we actually have a very limited palliative care service, which is really very sad. So of all these sectors which are sort of being looked at by the new models of care, the last phase is, in my opinion, going to need the most work to develop a world-class service within the Kingdom of Saudi Arabia. Okay, and I'm going to highlight an example of some of the problems in palliative care when we discuss the role of case management within these models. Okay, so to go over those issues that are being addressed by the new models of care again: keep well care, so primary prevention; urgent care, so life-threatening acute problems; planned procedures, so this is essentially elective surgery; safe birth and healthy childhood; chronic conditions, chronic diseases; and the last phase of life. So over the course of today, I'm going to talk to you about keep well care, urgent care, chronic conditions, and a very little bit about the last phase. Okay. So this is the summary in the document, and it highlights 42 different areas that are going to be addressed by 2030. Okay, so this is the aim for the kingdom. So inshallah, hopefully, we will actually by that time have totally transformed the map of healthcare in this kingdom. Okay, so keep well care. What are the plans? What does the kingdom need to achieve? There are 7 points that the program looks at. So they want health coach programs, and community-based wellness programs, and workplace wellness programs, and school wellness programs. So these are basically at the level of the community, they are organizing Keep Well programs. Food and nutrition is fundamental to health, and you can say we are what we eat. So a healthy food promotion program is fundamental to keeping well. So now they want to set up health edutainment programs. Now this is very interesting. It's a very interesting concept, because it's not just education. Because education in a way is is unappealing. So what we want is to engage people, so it has to be entertaining, okay? And they want to promote the function of the Saudi Center for Disease Control. So we have a community level program, we have a sort of governmental directed campaigns, and healthcare driven promotion. We have planned care. So to improve planned care, they want to set up one-stop clinics. So rather than the situation at the moment where what will happen is when patients need to come to the hospital, they'll come to one clinic one day, they'll be told one thing, then they go to another clinic the next day, and then a week later they go to another clinic, then a month later they have the operation. This is wasting a lot of time and resources. So what they want is, on day one, the patient turns up to one place, they see everyone they need to see, and then they have a date. The next date they come in, they have the surgery that they need. Now, this needs substantial reorganization of the system so that it is focused on individuals. So this needs engagement from multiple levels of healthcare or organizations to optimize these pathways. But one of the big advantages of this reorganization will be reducing the length of stay in hospital. So staying in hospital is very, very expensive. Okay, you know, a day in hospital may cost the hospital between 5,000 and 8,000 riyals a day. This is a huge amount of money. If patients, so every day the patient is staying, the cost of the healthcare is actually increasing. So keeping the length of stay down actually will improve the healthcare resources, and it also, hospitals are dangerous places. I'll come on to that again a little bit later, but there's risks of healthcare associated infections, medical errors, multiple problems can occur when patients stay in hospital. So not only would, by reducing the length of stay, not only is care safer, but it's also cheaper. Okay, then they also want to engage more step down and post-discharge services. So if patients are staying in hospital less time, they still need to be supported, and they still need to feel comfortable. And we as doctors also need to feel comfortable sending our patients home, knowing that they have support in the community. So this needs step down and post-discharge services. So these are the issues around safe birth, premarital screening, preconception care, maternity care services, national birth registries, postnatal care services, well baby clinics, and neonatal care services. So this package of interventions is designed to keep mothers, to help mothers deliver safely and help children grow up healthily. Okay, now this is outside the remit of this presentation. However, giving children a very healthy start in life has been demonstrated to actually reduce the risk of chronic diseases later in life. So actually focusing on this area is extremely important within the health transformation strategy, because dollar for dollar, when you put put money sort of behind programs, prevention is actually much more cost effective than curing diseases later on. So this is a very important area for health transformation. Urgent care, and we're going to discuss this again as a separate talk, but the Kingdom wants to set up resource control centres, and during the COVID pandemic, a very phenomenal control centre was set up, and we'll discuss a little bit more about that later. They also want to set up urgent care clinics. So at the moment, most of the urgent care is delivered by hospital-based emergency departments. So this is a very, very expensive way for caring for some more minor conditions. So by setting up urgent care clinics, it will free up the emergency departments and allow patients to be treated faster, because often patients with minor problems are given lower priority in emergency departments and can be waiting a very, very, very long time. And we need critical care facilities based on the needs of the population. And this was actually extremely important during the COVID pandemic, when we had actually previously a large number of ICU beds, but they were consistently full. So during the COVID pandemic, we actually needed to double the ICU capacity that we had in King Abdulaziz Medical City, and alhamdulillah, with the leadership and the organization that we had, this was set up very effectively and very efficiently by transforming wards into intensive care units. So the need for the population of critical care was met at that time. Then after the pandemic, and we're now at the the end, coming towards the end of the first wave, things were scaled back. So they actually have dropped back down to the level of critical care capacity that we had before the pandemic. So this document was very insightful in facilitating this flexibility within the system that allowed us to give the care to patients that they needed when they needed it, and then scale back when it's no longer needed. So this is actually an extremely important aspect, even though it's one single line in a very extensive document. This the flexibility is fundamentally important. Chronic conditions. So screening for chronic diseases, case management, and continuing care services are fundamental to improving the outcomes of patients with chronic diseases. So in the sort of terminology, this is the sort of prognostication, the risk stratification, and the primary and secondary prevention, and the treatment bundled and enablement bundled into all of these targets for the management of chronic conditions. The last phase of life. Now, this is a very sensitive topic. It's actually hugely underfunded and under-recognized within Saudi Arabia, and it needs a lot of work to bring this up to a world-class level of care for patients towards the end of life. Now, this needs a huge amount of patient and family support. And, you know, in the end, at this stage, the patient is unlikely to remember much of what happens. But the experience that the family have can be life-changing for them. It can be really a very, very distressing time. And, you know, as healthcare professionals, we have an opportunity to really touch people at this point in time. And this is one of the phases of patients, of people's sort of lives, when actually a teachable moment is created. So at that point in time, people are very receptive to suggestions about how to improve outcomes and change lifestyle and behavioral changes. So this phase and the sort of planned phase, sort of patients coming in and having operations, these are golden opportunities for healthcare professionals, for doctors, case managers, nurses, to actually really impact on people's lives and help them to improve health behaviors. Hospices. So a hospice is something that's very common in the West, but sadly, to my knowledge, is very, very, very sort of rare in Saudi Arabia. A hospice is a place where people receive end-of-life care. It's outside the hospital setting, and it allows a much more personal environment where people can still receive a degree of healthcare that they need to ensure that they're comfortable. So it's like halfway between dying at home and dying in the hospital, and and this is a much more personal environment, because in the hospital we frequently have to stop people from coming into hospital when their loved ones are at the in the last phase of their life. And this during the COVID pandemic was really horrible, very horrible. People were not allowed to see their relatives. Patients were upset. They were dying. They were dying, and yet they weren't able to be supported and have their loved ones with them. So the hospice environment should ameliorate some of these issues, and this really needs a multidisciplinary focus. It needs all healthcare professionals to come together and develop the actual ethos that the last phase of care is important. So hitherto, until now, we have really been focusing on the acute fare and trying to prevent problems. But at the end of life, there are many things that we can do to give patients and families the experience that they want, so that it can be as least unpleasant as possible. Chronic conditions. So health in all policies, virtual self-care tools, virtual education and navigation tools. So actually, this document was really insightful in the sense that this really laid the foundations for the transformation of the way that services were delivered during the COVID pandemic. Until the pandemic, many healthcare professionals were actually resistant to virtual care, telehealth, telemedicine, holding up the sort of gold standard of patients and physicians meeting together in a hospital, and saying that, if you go away from this gold standard and you can't actually meet with the patient, then outcomes are going to be worse. Yet during the COVID pandemic, literally overnight, the hospital set up virtual clinics, telemedicine, teleconsultation. This was really an overnight revolution in the way that we were actually looking after patients. So patients didn't want to come to hospital. They were afraid of getting COVID from the hospital. Healthcare professionals were uncomfortable seeing patients in enclosed spaces because they didn't want to catch COVID from the patients. Virtual healthcare was revolutionary in ensuring that patients with chronic diseases could still get the care that they needed when they needed it. Now, I'm actually involved in a study at the moment just to see actually were we able to maintain the standards of care. Did actually patients suffer from not coming to the hospital? My impression is actually they didn't have any adverse outcomes as a result of this, which is very important, and it will reinforce to my colleagues that actually we need to continue the model that was set up during the pandemic of virtual clinics. This is more convenient for patients, it's more convenient for staff, and it allows better utilization of healthcare resources. So it's a win-win situation for everyone, and it was really, it was really phenomenal that the health transformation strategy actually outlined these recommendations, up front, and recommended these changes that were actually, but it took the sort of a global pandemic to really move them forwards. And in this particular domain, over the last 6 months, there has been a phenomenal change. Okay, so now there's been less sort of emphasis on the last 3 components. So healthy living campaigns, school education programs, and enhanced primary care services. So having made great advances in telemedicine and telehealth and virtual healthcare, we now need to focus on healthy living campaigns, school education, and improving primary care. And we'll discuss the role of case management in some of these things a little bit later. So in addition to those things, we also want to improve home healthcare. We want to improve resource allocation and optimization. And we want to integrate personal healthcare records and develop national referral networks. Now, one of the big problems in the kingdom is that actually a patient may go to the hospital in the Ministry of Health, they may be fully investigated, they may have everything, but they may be unhappy with the opinion. So they come to the National Guard, and in the National Guard they don't tell us that they had all of these investigations. So everything is done again. And this duplication of work and effort is a vast waste of healthcare resources. So in the United Kingdom, we have the National Health Service. And this is actually a really phenomenal model for healthcare integration. So, for example, if I have a patient who I have who lives in another city, is normally looked after in that other city, and they come to my hospital, and I have no information about them initially, I can call their family medicine practitioner, I can call the hospital that they worked in, and they will send me all the records that patient has. So instantly, or not quite instantly, but within a day, I can have access to everything that that patient already has already had. Now, what that means is I don't need to duplicate that effort again. Even if the patient wants a second opinion, I can get the images that they had done, and I can get them re-reported. I can get biopsies re-reported. So these things actually massively reduce wastage within the healthcare system. Another problem is that there aren't any national guidelines. So for example, anemia is a very common problem, not having enough blood in the body. Now, in the United Kingdom, they have very clear guidelines about how to manage anemia. But when I came to Saudi Arabia, I was applying those guidelines here, and I found actually I was doing a lot of tests that were unnecessary, and the specialists here had a very different opinion about how patients should be investigated, but there was no national guideline to which everyone was working. So one specialist would say one thing, another specialist would say something else. So it was actually very difficult to navigate the pathways for our patients. So actually this needs a huge focus. And again, I'm actually trying to develop national guidelines for certain specific conditions that are relevant to internal medicine. And anemia is one of them. It's a very, very common problem that needs a lot of work. In order to see if the changes that we make are actually doing anything useful, we actually have to monitor outcomes. So, and this, we actually have to look at what happens to our patients. We need, in order to do that, we need to have a method to collect data. And once we have that data, we actually need to innovate and actually develop new ways of practicing and new treatments that are relevant to our patients. So this document is a very, very holistic overview of transforming the healthcare strategy within the Kingdom of Saudi Arabia. And all healthcare professionals have roles within that. And I would like you to just think about, what do you feel case managers can do within this framework of the new models of care? So what are your thoughts about what you think the role of case management is in bringing about this transformation in healthcare that the Kingdom desires by 2030? And what are some of the things that you're already doing that have been that were part of this document? So over to you again. Let's see what your thoughts are about this. Okay. So how can case management help to bring about the transformation in the Kingdom, the healthcare transformation? Okay, so we have a few suggestions here. So we have basically case management can coordinate healthcare. So this is very, very important. So coordination of multiple services is very important. So, okay, someone else is saying case management is can be involved in health education. This is excellent, exactly. So doctors and nurses do not always have time to explain everything in detail, And actually, case managers can often form a much more personal connection with patients and highlight times when physicians have not been able to fully address patients' concerns. Okay, so being involved in the communication and education is very, very important. Okay, that's very, very good. Okay, so case management is about advocacy. So basically, case managers are the patient's advocates. So they need to help the patient engage with the services that are available, and this has multiple different domains. So the healthcare providers are just one aspect of the things that case managers need to be involved with. So within this, the case managers can also engage with social services and the financial services that may be available to patients, and the ethical and legal issues that occur during the last phases and during sort of care for patients' lives that develop during the healthcare. We develop within the healthcare setting. So, healthcare providers are focused on one tiny part of the patient's lives. So case management needs to take a much more holistic view to evaluate the situation, assess patients, make a case management plan, collaborate with other sort of healthcare professionals and social services and the financial sector and legal services, and implement a holistic package of care that's appropriate to that individual, monitor the effectiveness of that and make any changes that are needed, and then evaluate again. And this cycle should go round and round. It's not a one-stage process. It will be modified by changes that occur. Okay? So medical case management is a collaborative process. It facilitates the treatment that is recommended by physicians and other healthcare professionals. And it ensures that appropriate medical care is provided. So it's important that you highlight if the patient is happy or unhappy with the treatment that they are receiving. And often case managers can have a much better handle on what patients' feelings are about this. Okay, so now case management is a collaborative model. It includes all healthcare professionals. It includes patients, nurses, social workers, physicians, other practitioners, and the caregivers and community. So the knowledge that you need is actually very, very broad. So you need to know how to engage with all of these practitioners and services. It must involve communication, and it has to facilitate care along the entire spectrum, and it has to effectively coordinate resources. And in this way, it engages with every domain of the health transformation strategy that the Kingdom has for Vision 2030. So the goals of case management are to improve health and improve access to care when needed, and allow resources to be used appropriately. But this has to be balanced against the patient's right to self-determination. What that means is that patients ultimately have the right to choose what aspects of the care that they are offered that they actually want. They cannot demand treatments that they don't need, but they can actually choose not to have treatments that we offer, and that's their right. Okay, so within the context of the new models of health, the case management process is fundamental to reorganization of this of healthcare within the kingdom. Okay, so this process, from screening, assessing, planning, implementing, following up, transitioning and evaluating, and stratifying risk, and communicating with with healthcare professionals during changes in transition of care, is a fundamental role of the case management process, and it is important to the new models of health. Okay, what I'm going to do actually is I'm going to take a break now before I give you the example of medical case management in the last phase. Okay, I think we had planned to to have a break. Now I think I've run over a little bit, so if we give you a 15-minute break now, and I can take any questions that you have now, and we'll aim to come back after the break at about 10 minutes past 11. Okay. So we have had some more comments about what case managers do, and they've said, yeah, ask family if they have any imaging reports, they can bring it to the hospital. This certainly will help streamline healthcare. Another person has said, enhancing healthcare. Definitely, case managers will enhance healthcare, and they certainly do help in building strong relationships with families and patients. So, you know, these things are very, very important aspects of the role of case management. We'll restart at 10 minutes past 11, inshallah. Assalamu alaikum. We should restart the course, but we did get some questions during the break. Now, okay. Yeah. So the people who have just made some comments about are we in a break? We were in a break, and the break is now finished, and we're restarting the presentations again. Okay. Actually, I should probably make a slide that is a slide for break time and when it will end. So that's actually very helpful feedback. I'll do that for the next break. So the issue is, during the break we did get some questions, and there was one very interesting question, which was basically what and how, in your opinion, can case managers do better in NGHA to improve patient outcomes during the patient's inpatient stay? Well, I'm going to be answering that question over the course of the presentation, but you've already begun. Attending this course is actually very good. It will give you an insight into the roles of other healthcare professionals and the roles of case management, and inshallah, attending this course will help you have a better knowledge, and some of our experience and our stories that we tell you will help form and change your approach to case management. But I'm going to give you some more specific concepts about how case managers can help to improve patient outcomes, not only in NGHA, they will be applicable worldwide. Okay, so and actually, to come back to the presentation, we are going to start with an example of how case management really transformed a palliative care service in actually the United States. But the principles of and problems are exactly the same problems that we face here in National Guard and throughout Saudi Arabia. So the first thing that the case managers did when they started working with the palliative care team at this organization is they actually sat down and said, okay, what is the process map of a patient coming through this service? And then they sat down and they said, okay, which problems are affecting patients at each stage of this process? So the very start of the process was sort of inquiries about patients who were feeling unwell, and they wanted to come and see the palliative care team. So basically, there was a difficulty with patients accessing the service, and the problem was that there was no single point of access. The patients would call the doctors, they would call the nurses, and a central office. So basically, because patients were calling multiple different people, no one had an overview of the work that needed to be done and the patients that needed help, and there was misinformation given to multiple different people. And this was made worse because communication wasn't clear. So there was no clear line of communication. The patients needed care to be directed to the problems that they had. But the problem with the last phase of life particularly, is that it can progress very quickly. So patients may not have pain at one particular time, and then they may suddenly develop pain shortly thereafter. So what is needed is a very flexible response to patients' needs. But the previous system was basically based on the doctors reviewing the patients once in the morning, and then they would not see them again until the next day. So this meant that if something changed during the day, this was very rarely dealt with that same day. And there was a insufficient networking between the Department of Palliative Care and other departments within that hospital, and even other hospitals. So the first thing that the case managers did was actually set the priorities that identified the problems and set the priorities for trying to address those problems. Okay, so what did the case managers do? They said, okay, they wanted to optimize patient care. So what they did is they performed a needs assessment for each patient, and they accompanied some patients as they were needed. Okay, so and they performed a risk assessment to say, okay, this patient is low risk, this patient is medium risk, or this patient is high risk of needing a lot of input from case management services. And I'm going to talk about that sort of process a little bit later as well. And it's one of the things that could improve the case management coordination and improve patient outcomes in our hospitals. So basically, the case managers agreed that they would be the single point of communication to external inquiries. So rather than patients calling, having access to multiple different avenues, they would have to contact the case manager, who would then direct the the query to the relevant provider. And the case manager would also communicate with each of those providers. So this actually, the single point of communication, transformed the communication between the services. It reduced misinformation, and and patients were happier because everything was clear, and they were given a very clear pathway of how to access the service. Okay, and this also took away some of the burden of the work that the physicians, nurses, and social workers had to do, because the case managers were taking all the referrals and calls and then directing the inquiries to the most appropriate service. And if admission needed to be organized, then they would facilitate this and then communicate what was happening back to the patient. So a huge burden was taken away from the physicians, nurses, and social workers. Okay, so this is the sort of network diagram of the processes and how the case managers helped to deal with that. So there were multiple people who are making sort of inquiries into the system, and the healthcare professionals were dealing with that. Okay, and there were multiple different services that were provided, and so what the case managers did was they sat down, looked at the entire process map, and then at each stage identified problems, delays, barriers to accessing that service, and things, and looked at the complaints that were received by patient relations to see, okay, how can we improve the system? And then by creating a single point of access for communication, it transformed the system. So that's just one example of how case management can actually really improve patient outcomes. Okay. Now, another way to improve patient outcomes is to remember that actually hospitals are very dangerous places. So, and although all healthcare professionals come to work with the intention of helping people, unfortunately, there is a lot of evidence demonstrating that about 1 in 10 patients who come into hospital may actually be harmed. Now, there are many reasons for that. Staff shortages, technology failures, inadequate training and supervision, and problems occur when the holes in the Swiss cheese line up. Now, what I see as a fundamental role of case management is plugging the holes in this model. So basically, by coordinating care, identifying problems, highlighting these to the relevant healthcare provider, case managers can really facilitate the coordination of care and reduce harm to patients. Okay. Now, coming on to the next aspect of the talk, health prevention and health promotion. Okay, so this is a hugely important role for case management, and there is some terminology that sort of distinguishes the two. So health education is at the center of a much wider strategy of health promotion. So, both health education and health promotion involve aspects of societal, economic, political, regulatory, policy, and organizational factors. So, health education is on a much more personal level, and health promotion considers aspects of improving individual and population health on a much broader scale. And as highlighted in the health transformation document from the Vision 2030, it is fundamentally important to improving the health of the population within the kingdom. Okay, so if we break those two things down, health education is based on developing and making and constructing opportunities to educate and communicate with patients, with the aim to improve health literacy and increase the knowledge and develop the life skills of those individuals and communities to improve health. Now, as I mentioned before, some of these opportunities are dependent on patients' stages in their lives. So a key teachable moment is when a patient is coming in for surgery. They're often very afraid, and they're very receptive of advice as to how they can actually improve their outcomes. So we should take these opportunities to give people advice about healthy and unhealthy lifestyles, and I'll come on to the advice that we can give them at that stage. Another stage is at the last phase, when people, when families looking after loved ones that they can see are deteriorating, are also very, very receptive to things that will that can change their lifestyles. It's not only about giving people information, it's about motivating them. It's about giving them skills and giving them confidence that actually they are the people who are actually in control of their health, and they can actually do things that will impact on their own health. So, and it's not just information about health, it's information about social, economic and environmental things that actually increase risk of patients developing diseases, and highlighting behaviors that are risky or dangerous to people's health, and telling them when, okay, the healthcare system is there to look after them, what the healthcare system can and what it cannot do. So these things are extremely important, and it will involve some communication of information, and it will also involve helping people to develop life skills. But it must also demonstrate the feasibility within the organization. Okay, it must demonstrate what can be done and what cannot be done. So in this way, we need to manage people's expectations. We cannot promise that everything is going to be better. We have to ensure that people are realistic about what can be achieved. So an education, health education, is important in ensuring people access the care that is available, but they also have realistic expectations about what it is possible that can be done. And the action that is involved in health education will address the risk factors, which may be at the level of the society, the economy, or environmental factors that are relevant to an individual or a community. So, in summary, health education is a combination of planned learning experiences using evidence-based research that provide opportunities for individuals or communities to acquire knowledge, attitudes, and skills that are necessary to maintain healthy behaviors. So that's health education in a nutshell. But what about health promotion? So health promotion is the whole process, the process of enabling people to improve their health. And it's a very comprehensive package, and it's really encapsulated by the transformation strategy for Vision 2030. And it involves, again, changing the conditions within society, the environment, and the economy to reduce any adverse impacts on public health predominantly, but by improving public health, individuals will benefit. And this process of health promotion will increase communities' ability to control things that determine their health, and so increase their ability to improve their own health. So this is a partnership. Health promotion is a partnership. Health education is a partnership. It's a partnership that needs participation of the governments, the healthcare organization, the healthcare providers, and the patient to sustain any actions that are initiated in a health promotion program. So, we can see this sort of concept in the virtual clinics that were set up in King Abdulaziz Medical City. So they were phenomenal during the COVID pandemic. They worked extremely well, and yet immediately when the as the sort of measures were scaled back, the virtual clinics almost stopped, and we went back to the same traditional model of outpatient care that was delivered. Now, we all recognized the huge benefits of virtual health, and yet things have gone back to where they were before. So we failed to sustain those benefits, and within the organization we're working to actually capitalize on what we learned during the pandemic about telehealth, and moving forwards set up a separate stream of chronic healthcare delivered virtually. So we can have the traditional model running parallel to a virtual model. So the Ottawa Charter is a Canadian strategy for health promotion, and it basically encapsulates 3 strategies in which case management is actually fundamental. So advocacy for health. So basically case managers need to advocate for people to improve their own health. So we need to create conditions that are essential for health. So we need to ensure that people are aware of what can be harmful and what is beneficial to their health, and advocate those things. Then we need to enable people to achieve their full health potential. Unfortunately, the people's health is not going to be the same. People's health is going to be limited by the medical problems that they have. But within that limitation, we can help people to achieve the best health they can, the best quality of life they can. And in order to achieve that, we need to mediate and communicate between the different factors and interests in society that are relevant to the pursuit of being healthy. Okay, and so the Ottawa Health Charter outlined 5 priority action areas that are also that summarize the vision of the 2030 Health Transformation Strategy. So these 5 principles are building a healthy public policy, creating supportive environments for health, strengthen community actions for health, developing personal skills, and reorient healthcare services. And the example that I gave you of the case managers in the palliative care in the last phase setting, they actually engaged everything except the first point. So they created a supportive environment within the palliative care department. They strengthened community actions by facilitating the transmission of information and knowledge between all the concerned parties. They developed personal skills. So they developed the patient's skills by providing education about things that can help them in their last phase of life. And they actually reorganized the entire service by saying, okay, rather than having all of these multiple avenues for communication, we are going to be the single point of contact for access to this service, and then we will direct the information appropriately. So this is how case managers can engage with the health promotion process and improve patient outcomes. Okay. Now we're going from the health promotion back to the healthcare education on the individual level. So I'm going to talk about healthy and unhealthy lifestyles. Now, I'm sure you can all tell me, when you think of, when you hear the term unhealthy lifestyle, what comes to your mind? So if you just send some ideas about unhealthy lifestyles and lifestyle choices, what do you think are things that we need to advise our patients that could be damaging to our health, to their health? So if you can just send some ideas through on the question and answer on Teams. Okay. So we have some ideas here. So fast food, junk food, yeah. So not doing enough exercise. Yeah. Now all these are very, very good ideas about unhealthy lifestyles that we should advise our patients to avoid. Now, so breaking bad habits is very difficult, and there's no absolute line that distinguishes healthy and unhealthy lifestyles. Unfortunately, as people, we are all going to have some naughty moments when we actually do things that we know are unhealthy. Now, the challenge is that if we say we should never do those things, this is unachievable. However, we should actually limit those things as much as possible. So, food, healthy eating, and harmful food. So, whilst we can recognize the junk food that we see in the bottom part of the slide is unhealthy, it tastes good, and certainly just telling people don't eat junk food isn't going to work. We need to advise them, okay, what are the benefits that you're going to get by healthy eating? Well, you'll feel better, you'll move faster, you'll think more clearly, and then we also need to tell them what food is better for them. And within our organization, we have nutritionists and dietitians who can specifically advise people on healthy eating that is relevant to their health needs. Because healthy eating for one condition and disease is not exactly the same as healthy eating for another condition. So, and I'll touch on those things a little bit later in the talk about chronic diseases. Okay, so healthy lifestyles, we need to take more fruit, get enough sleep, take enough water, control our weight, eat more vegetables, and reduce stress. Now, the unhealthy lifestyles we should avoid. Now, just to think about COVID-19. Now, unless people have been living in a cave for the last 6 months, they will have realized the huge impact of COVID-19 on our lifestyle. And it is amazing that we can spend a lifetime developing good habits and doing good things, and yet within a few months, everything has totally changed, and we are not able to do what we wanted or were able to do before. And certainly for adolescents, this has been a major cultural change. And I was involved in a survey. So this is just to show you some interesting data from actually an international survey that we conducted at from the National Guard. This slide shows the places that we've got responses from adolescents who were concerned about getting COVID during the pandemic. And we got responses mainly from Saudi Arabia. The vast majority were from this kingdom, but we got responses from all over the world. And this is really interesting because essentially, if we see what adolescents were doing, well, they got more screen time, they were sleeping more, they had a bit more time for their family and for themselves, but their physical activity and their time with their friends dropped substantially. And many of them were a little bit worried about getting COVID-19. So basically, the lifestyle became extremely unhealthy. So during the COVID pandemic, people were not doing physical activity and they were sleeping and playing video games. So this actually is a public health disaster. Okay, and we actually need to do a lot of work now to undo the damage that has been done by encouraging people to live much more healthy lifestyles. Okay, and in many parts of the world, there's now a second wave of COVID-19. So we should also prepare, thinking, okay, if this happens again, what are we going to do? Well, personally, I got myself an exercise bike so that I can do a little bit of exercise whilst I'm being locked down. Okay, so health promotion and education for all ages depends on the stage of life. So basically, at birth, so mothers giving birth need specific interventions. Children, as they're born, need other during childhood need other interventions, immunizations, support for development, school, parity in education. In the 21st century, being IT literate, information technology is fundamental to accessing everything, but particularly healthcare, because everything is going online. And as I said, we're sort of setting up virtual clinics, so people must be IT literate, and this all comes into the remit of health promotion. So health promotion varies between ages. So I'm just going to illustrate the differences between health promotion at different stages of people's lives by playing this video, because certainly this video would be Okay, I hope you enjoyed that video, and this is something that's actually very, very important for case managers to consider, depending on which service that they are working in. The materials that you use to help education need to be age appropriate. Now that my children loved that video, and they were encouraged to eat healthily, and but for I have a 16-year-old who wasn't quite so engaged by that video, but this sort of information infographic was much more appealing to her in terms of encouraging her to do things during the COVID-19 pandemic as a practical advice about how to keep herself busy and active during the COVID pandemic. But again, this wouldn't be appropriate for older adults. So this sort of information is much more relevant to older adults. And so each different age group requires a different approach to promoting health and sustainable development. Okay, so that's very, very important to consider. Now, in the last few minutes before the break, I'm just going to talk to you about behavioral change and how, what we can do to help people actually sustain improvements in health. Now, when we think about stages of change, people actually need to think about that they want to change, and before they even think about it, that something has to occur that makes them want to think, or makes them recognize that there's a problem. Okay, and as I've highlighted, there are some specific teachable moments that create this pre-contemplation stage in people's healthcare journey. At that point in time, we can actually motivate them and tell them that, okay, if you do this, then you can improve your life. Then we need to direct them to resources that will help them learn what they need to do. And then we motivate them to take action, to actually maintain, to implement the things that they have learned. Then once they've started doing those things, they need to maintain the change that they have implemented and stop relapses. Okay, so relapses are very unhealthy because they're like little failures, and when people fail, they really struggle to get back onto the horse or the bicycle to start riding again. So we need to help people. We need to create those teachable moments. We need to help people think about what they can do, tell them what they need to do, guide them to resources that they need, motivate them to action, and help them to maintain the behavioral changes that we advise. Now, this model illustrates the probability of success of any change. So basically, when your motivation is low, it's very, very likely that any intervention that you try and make is going to fail. But when your motivation is high, when your motivation is high, it's much more likely. When your motivation is high, it's much more likely that something is successfully going to trigger a behavioral change. So the motivation is key, and case managers are key to highlighting the benefits that people can get from healthy lifestyles. Now, when we think about, okay, when we say, okay, these are the things that you can do to change your behavior, there is a hierarchy of how effective those things are going to be. And the most effective is not giving someone any other option. So, for example, if if a if a patient is being fed by a tube feeding, a PEG tube, they actually have no other way of eating. They are forced to have the tube feeding. So this is a very, very effective and efficient way of increasing their intake and increasing their nutrition that they receive. However, it's not, we can't put tube feeding into everyone and force feed them. So there is a hierarchy of effectiveness of these tools, and reminding people can be effective. Going over things, giving people checklists, and then double checking that they did what you've recommended is very helpful. And education and giving people access to information is important, but actually it's relatively ineffective. And certainly just telling them to be careful is probably the least effective. However, there are studies showing that at teachable moments, the effectiveness of these sort of education and be careful, be vigilant advice is highest at that time. So, for example, if a patient is coming in to have surgery, telling them to stop smoking is very highly likely to be successful, because patients are very motivated at that point to try and help themselves. Similarly, towards the end of life, when families are visiting their loved ones, discussing that smoking is harmful to health, and mentioning that can actually transform the lives of the visitors and the relatives. So thinking about this hierarchy and trying to use the most effective tool to implement behavioral change that you have is important. Okay, so once again, this comes into the Ottawa Health Charter and the strategies for health promotion that we've discussed above. Okay, so now within that framework, medical case management needs to bring the whole thing together by considering the medical aspects of what are recommended, the patient preferences, and and considering what the patient wants in terms of quality of life, and putting that all into the context of the patient's family, the law, the hospital policies, and if insurance companies are involved, what those things provide. Okay, so that is a summary of what doctors do, what case managers do, the health education and promotion, and healthy and unhealthy behaviors. So that's really the first chunk of what I wanted to talk to you about today. And we're going to have a break and a prayer time now, unless there are any questions that need to be answered. So we'll have a 25-minute break. We'll come back at 12:20. But if anyone has any questions, I'll take them now. But in the interim, I'm going to put up a break for a slide that shows a break. Okay. If anyone has any questions, please ask them now. Okay. All right. So,
Okay, there is no questions, so we will go to the break. Can you just, doctor, mute your mic?
Okay, will do.
Assalamu alaikum. I hope everyone has had a refreshing break and done what they needed to do. So inshallah we will start again. And the next topic is an overview of urgent care. And this is one of the domains in the health transformation strategy from the Vision 2020 document. And I'm going to go over some of the aspects of urgent care that are relevant to case managers. Okay. So the lecture plan for this lecture is to describe the scope of the emergency department, the scope of the urgent care clinics, and the resource control center that have been outlined in the transformation documents, and then case coordination in urgent care. Okay, so we come back to the point about what do doctors do, and I said, you know, doctors are essentially involved in each of these four things essentially, which includes a risk assessment, prevention, primary and secondary, enablement, and treatment. So in the emergency department, what do doctors do? Well, the basic advanced care of acute diseases, which is the remit of the emergency department, is exactly the same. So the scope of the emergency department is the same. But what do the ER doctors do? They have to do this faster than the other doctors in the rest of the hospital. They're doing exactly the same things, but they're doing them faster. Okay. Now, if we think about this emergency department, all the patients are leaving, and this is what the administration wants. They want the patients to be seen and dealt with quickly and effectively, and they want to see people, well people, leaving the department. The reality of the situation is extremely different. So you get very, very sick, unwell patients coming in all hours of the day, without, often without any warning, and the emergency department doctors have to deal with whatever comes through the doors. So the role of the emergency department is, as every other medical department, to provide patient care, evaluate and treat patients, and they may be specialized. So there may be emergency department specifically for children, or specifically for adults, or it may be a general emergency department that takes all patients of all ages, and the levels of illness can vary from very minor to critical. Okay, so it is a very, very broad remit, and there may be specialist services within the emergency departments depending on how advanced they are. They may have stroke centers, they may have cardiac centers that deal with patients who have acute strokes, or patients who have acute heart attacks, or major trauma. Not all emergency departments are fully equipped to deal with all of these problems. So, however, at the National Guard King Abdulaziz Medical City in Riyadh, we have capacity to deal with all of these specialist conditions, and there is a separate adult emergency department and a separate emergency department for children. But not all facilities will have that degree of specialism or capacity. So if a department doesn't have the capacity to deal with a problem the patient has, they will need to transfer that patient to another hospital to obtain necessary treatment. So if a patient is actually managed within the emergency department, essentially there are a few different possible outcomes. So they are usually the vast majority are sent home with follow-up instructions. The patients with very minor problems are fast-tracked and where we try to send them out very quickly, and they can be discharged immediately after treatment. Some of them who require some attention after their treatment may be kept within the emergency department for treatment. However, some patients who have more serious problems that need to be in hospital for a longer period of time will be referred to an appropriate specialty within the hospital and actually admitted into the hospital under that service. So the classical pathway of clinical assessment that we read about in the textbooks is about doing a sort of oral assessment of taking a history from them, examining the patients, then doing some investigations, and then treating them. However, if we did it that way, it would be very time consuming, and in real life, in the hospital as well as in the emergency department, everything is done simultaneously. So we'll be assessing the patient while ordering some investigations and initiating treatment, because the emergency department has to go faster, because there are huge numbers of patients and they have to be seen, and many of them have life-threatening problems which have to be dealt with urgently. Now, the problem is that when we see patients in the emergency department, often we don't clearly know what is wrong. So we'll have patients who are, who are told that maybe you have a pneumonia, maybe you have heart failure, and we're going to give you the treatment for all of these, and hopefully one of these things is going to make you better. And the problem is really that when we think about the way that problems in the body can present with, for example, breathlessness, there are many different things that can cause that. And it's very difficult to be certain which of those things it is in the emergency department within a few minutes or hours of the patient's arrival. Over the fullness of time, over the next few days, once people are admitted to hospital, we have a clearer idea. But often the emergency department treatment is actually aimed at multiple different problems, and it's very difficult to be specific. Now, when we think about the urgent care clinic in comparison to the emergency department, there is certainly a big overlap in the services that they provide. Now, urgent care services are similar to outpatient, more like outpatient clinics. They're same-day clinics, often open 24 hours, that can handle many medical problems that need immediate treatment or urgent treatment, but they are not true life-threatening or limb-threatening emergencies. So the scope certainly overlaps with family medicine, which is generally office-based and only 8 till 4 service, and also overlaps with the emergency department. So there is a focus on acute medical care, but at the lower end of the severity spectrum. So it does address illnesses and injury that need professional attention, that could become life or limb threatening if treatment is delayed more than 24 hours, but isn't life or limb threatening now. So the sort of things that the emergency, so that the urgent care center can manage are nausea, back pain, simple pneumonias, simple fevers, sprains, insect bites, some minor
minor sort of injuries. So the challenge is that there is no access to extensive tests, to lab tests or advanced imaging, and patients who require this need to be transferred to the emergency department. Okay, so essentially, patients need to be triaged to the most appropriate service to manage their problems, so that whilst an emergency department can manage everything, patients will be waiting a significant period of time if patients with very small problems all go to the emergency department. So how do we direct patients? Well, the transformation document has recommended the development of resource control centers to ensure health challenges are managed systematically in a holistic and comprehensive way. So during the COVID pandemic, a national control center was set up that had 11 functions within it that were all controlled by a control tower. It wasn't actually a physical control tower, it was a virtual concept that had overarching control over the other domains. An important aspect was to coordinate between multiple different governmental organizations and departments. So and with a focus on public health. It therefore needed a medical advisory council to advise the government and the public health departments. It needed a division to cover labs and diagnosis, because this was specifically relevant to COVID-19, and the scale of the testing had to be set up on a national scale. So it wasn't possible for individual hospital labs to screen the population. Then there was epidemiological support that was needed, and this was similar to that is needed during Hajj, in the sense that a huge population level analysis of what was happening with the COVID pandemic was being monitored. An infection control arm was needed to facilitate control of the spread of COVID-19, which was then integrated with the epidemiology support and the public health service through the control tower. The control tower also had to develop extra capacity. As I mentioned earlier, we needed, we had to double. We had 100 ICU beds at King Abdulaziz Medical City. At the height of the pandemic, we had 200 ICU patients. We had to double the ICU capacity that we had, and this was done locally, but also in coordination with the Resource Control Center, who were advising on the additional capacity that was needed, and transferring patients within Riyadh between major hospitals, so that King Abdulaziz Medical City, we took pressure off the Ministry of Health that were overwhelmed. Then there were sort of clinical operations in liaison with the Medical Advisory Council to set up new field hospitals. The data was from the pandemic was being analyzed real time to guide all of these departments. And there was a communication arm, not only for within the Resource Control Center, but to the media and to the public to inform them of the situation. All of these aspects of healthcare were under the remit of a single control tower that was that had overarching control of the resources and the response to the situation. And alhamdulillah, when we look at the outcome of COVID-19 in Saudi Arabia and compare that to elsewhere around the world, the United States is a disaster, and even the United Kingdom has the number of deaths was about 6%, whereas within the kingdom the mortality is only 2%. I mean, this is actually remarkable and is a testament to the phenomenal response that was put into place during the COVID pandemic, and all of the response that was put into place was actually aspects of the health transformation strategy from the Vision 2030 document that had already laid the groundwork for these things. They hadn't quite reached the front line of clinical service, but the pandemic was really the push that that accelerated this process and also increased the funding for healthcare to facilitate the development of these services and systems, which have subsequently been scaled back, but the benefit was fully realized during the COVID pandemic. Okay, so that's urgent care. Now, if you bear with me whilst I change slides set to the next phase of the presentation. Okay, so I'll just check if there are any questions about the acute care services and see. Okay. So we have some questions here. Okay. So the questions. So we have some questions about when departments in the hospital have to call the case managers, and a similar question is is there any manual guideline for units in the hospital to show the role of case managers? Okay, so there is these are very interesting questions. So there isn't a manual or guideline in Saudi Arabia for the role of case managers. It's a model that has been developed from the US healthcare system, and in that system, case managers basically facilitate patient flow and are given clear targets and guidelines of for discharge of patients and preventing readmissions and being advocates for patient health. So rather than departments calling case managers are fully integrated within the service that the department provides. So, for example, in the example that I gave you of the palliative care service, case managers were joined the department, and they said, okay, what can we actually do to improve the service that that is in place? They then did a process. They looked at the process map of the patient journey, and then on the basis of that process map, they said, okay, these are the key areas where problems are occurring, and these are the key high yield areas where if we make an intervention, we can actually improve patient flow. And so they took on being the single point of access of communication. So in that way, the service was improved. So there's no manual, but the remit of case managers is to actually improve the efficiency and the organization of the system. And so I put it to you that you can actually look, because you will know where the problems are within your system, and if you don't, then a process mapping day with some stakeholders within the process will actually highlight the areas that need to be addressed. Okay, so okay, I'll come back to the advocating patient who's relapsed smoking cessation. I'll come back to that question later. Okay, but for now, because it's actually relevant to the chronic diseases. Okay, so now this is the sort of last phase of the presentation, but it is going to go across our break. So we'll talk about chronic diseases for about 20 minutes, and then we'll have another break, and then we'll finish the presentation today. So the course outline that we're going to be discussing is Keep Well Chronic Care, and this is going to overlap a little bit with the talk about health promotion, health prevention, and healthy behaviors. I'm going to give you an overview of chronic diseases in Saudi Arabia, and talk about the basic management of specific chronic diseases, okay, to give you some insight into what services patients will need and how long roughly you can expect patients to stay in hospital, and from that perspective you can actually target the interventions that you need to do so that they are completed within the time frame, the expected time frame of the patient's journey through the hospital. Okay, so we come back again to the 4 Ps and what doctors do: the risk assessment, primary and secondary prevention, enablement, and treatment. And these are essentially, as I mentioned, involved in the basic and advanced care of acute diseases, and it is exactly the same for chronic diseases. So all diseases follow or require the same medical model of management. Okay, so chronic diseases in Saudi Arabia. So this is data that is 18 years old now, but it's a comprehensive review of the causes of death in Saudi Arabia up to that point. And actually 70% of deaths was due to non-communicable chronic diseases. So cardiovascular disease was a huge component, and certainly the lifestyle and the culture within this kingdom actually actively promotes cardiovascular disease, and we'll come on to that again later. Cancer was about 10%. Chronic respiratory disease was a small amount. Diabetes was 5%, but it contributed to a chunk of the cardiovascular disease, and other chronic diseases were another 15%. So 70% of healthcare of deaths in Saudi Arabia were because of chronic diseases. So we're going to spend a little bit of time thinking about that. Now, my philosophy for patient care is based on this principle, which is aggregation of marginal gains. I'm going to explain that, but before I do that, I want you to just think about how you would prepare to win a cycling race. Okay, if you wanted to win the Tour de France, would you exercise only your legs, or would you undergo intensive holistic training for your entire body, optimize your nutrition, and enhance the equipment that you had, your bicycle? Of course, you would do all of those things. You wouldn't just focus on the pedals. So this is a principle that was actually sort of crystallized by David Brailsford in around 2010, and he was a performance coach of British cycling. So he was tasked with improving the performance of the team, and before he took over, they lost everything. The team was useless. Okay, he came up with this concept of breaking everything down that he could think of that goes into riding a bicycle, and then focused on improving it by 1%. He said, you know what, our athletes are fantastic. There's no way that we're going to improve their performance by 20%. It is impossible to improve the athlete sort of performance. but if you say, okay, we're going to improve the nutrition, we're going to improve the training, we're going to improve their sleep patterns, we're going to change the bicycle, we're going to change the wheels, we're going to change the gears, we're going to change we're going to ensure that the vehicle that the bicycles are being transported in is spotlessly clean, so there's no dust that is going to get on the bicycle before the race. So all of these things will have a small improvement in the performance of the cyclist. And when you add all of these small improvements together, you get a significant increase in the performance. So this is the approach that I use when I'm managing chronic disease, and considering and this is actually the principle that is engaged in the new model of care by making small improvements as much as we can within each of these domains. We will have a huge overall improvement in the health of the population. Okay, so when we think about chronic diseases, the patients are referred from the primary healthcare service to the hospital, and then we assess them, advise, agree on a plan, assist them to execute that plan, and then arrange any further interventions that are needed, and then follow up what was done. We recognize that the chronic diseases may have a course that occasionally flares up and gets worse. So if there's an exacerbation, we will have to manage that. And then when that settles down, the patients are return home and are managed by their primary healthcare providers. So that's the basic overview of the general management of chronic diseases. So now we think about length of stay in hospital when these patients with chronic diseases are admitted. So what we have here is a graph showing various different countries' average length of stay. And we can see Australia actually is very low at just over 4 days per patient for all acute conditions. And Japan, at the other end of the scale, the average length of stay is very long, 16 days. This is a huge amount of time in hospital. Saudi Arabia isn't there, but where? So can anyone sort of tell me, where do they think? I mean, I have data from King Abdulaziz Medical City, so I can tell you exactly from our hospital. But broadly speaking, the management and the approach is the same throughout the kingdom, so it's going to be the same. So what do you think? Just put some numbers on the Q&A, a question and answer. How long is the average length of stay in hospital in Saudi Arabia for acute conditions? Someone's asked me, am I a COVID survivor? Alhamdulillah, I don't think I've had COVID. But now, how many days? So someone is saying 5 days. Someone has said, what other days? How long are people saying that they're in Saudi Arabia? The length of stay in Saudi Arabia. Okay, so I'll tell you, it's actually just over 9 days. Okay, so 9.5 days is the average length of stay in Saudi Arabia. Now, now that's vastly better than Japan, but almost every other country on this graph is showing a spectrum of conditions, a spectrum of time from 4 days to 9 days. Now, what this tells us is that actually we can make significant improvements in our length of stay by considering what these other countries are doing. So this is particularly important to be aware of because winter is coming, and winter is a time when there are bed crises. The hospital beds are all full. The emergency department gets blocked. If the emergency department gets blocked, then patient care slows down. The other thing to recognize is that the length of stay varies depending on the condition that the patient has. So this data is not from Saudi Arabia, but broadly speaking, the data is exactly the same around the world. So when we look at pneumonia, what we can see, you don't need to focus on the numbers, is that actually as people get older, the length of time they stay in hospital for each of these problems increases. And once patients are getting above 75, the average length of stay can be in the order of months. And when we think about the diseases, so the first one was about pneumonia and COPD. This next one is about diabetes and heart diseases. All of these conditions, the older the patients are, the longer they stay in hospital. Now, what I wanted to highlight was actually mental and behavioral disorders are amongst the most difficult to treat. And as patients get older and older, patients with mental health disorders like schizophrenia and dementia become essentially institutionalized and do not leave a healthcare environment and spend the last days actually in hospital. So this is actually very, very important to recognize. When patients come into hospital, we need to actually try and preserve their orientation and their mental health and prevent them from becoming confused and developing depression. Because actually, the factors that prolong length of stay much more than the actual physical disease is the mental health of the patient. Okay, I'm just going to go over now some specific chronic diseases that I was asked to cover in a few minutes, and then we'll take another break, and then come back for the to conclude the session on chronic diseases. So asthma is a very, very common problem within this kingdom, and it's a problem in the lungs that has three facets. So the airways get blocked because of spasm of the muscle, because of inflammation of the airways, and because of mucus blocking the airways. Now, the thing about asthma is that it presents with shortness of breath, wheezing, and coughing. And it's triggered by allergens, dust, mold, and exacerbated by smoking. So, so infographics like this can be very helpful to patients in terms of showing them what they should avoid. So, sorry, I'm getting some messages on the. Okay, so I've answered those questions already. Okay, so so the problem that occurs in asthma is that patients get less air than patients who don't have asthma. Now, there is an overlap between asthma and other allergies. So, and there is also an overlap with another problem called chronic obstructive airway disease. Now, this spectrum of disease, asthma and COPD, are very, very similar diseases. The difference is that patients with asthma tend to be younger, and we tend to be able to get them better quickly. The problems that occur with asthma are exactly the same with COPD, but actually they are now fixed. So it's actually very difficult to get them better. So
Dear all, we will be having a 10 minutes break.
Okay, welcome back everyone. We're coming to the final phase of the lecture now. We had a slight technical hiccup, but actually it was around the time that I had planned to stop anyway. And I'll just restart with the going through briefly a few aspects of chronic diseases that are relevant to case managers. So as I was saying, asthma is a disease that causes three problems that result in difficulty breathing. So it causes muscle spasm, it causes inflammation of the airways, and it causes a lot of mucus production, which results in wheezing, breathlessness, and coughing, and means that patients get less air than people with normal lungs. There's an overlap between asthma and various allergies. So many things can actually trigger asthma, and part of the education to patients is to avoid those triggers, which include smoking. Now, COPD is a very similar problem to asthma, but it's much more difficult to treat. The same problems are actually fixed, whereas in asthma, they are more easily reversible. What that mean, and the patients with asthma are generally younger than the patients with COPD. Now, what this means is the patients with asthma, generally, we can treat them and improve them very rapidly, and they can be discharged from hospital if they need to be admitted at all, within 24 to 48 hours. Whereas patients with COPD, with chronic bronchitis or emphysema, will stay in hospital for much longer, often 3 to 5 days, and they will need much more intensive therapy, and they have a much higher chance of needing other treatments and even going to the intensive care unit. So acute bronchitis is often an infection that settles very quickly, but chronic bronchitis is a very difficult to treat problem once the problem has actually caused substantial long-lasting damage to the patient's lungs. Bronchiectasis is another problem that's common in Saudi Arabia, which has a similar sort of pathology. It's often related to childhood diseases or tuberculosis. So this is another very common problem in Saudi Arabia, which actually is even harder to treat than COPD. And so these patients tend to stay even longer. Now, the patients with these respiratory diseases will often need some equipment that they may need to take home. So they may need to have an oxygen concentrator. They may need to have a BiPAP machine. And they may need to have a suction machine. So when the patients come in with these problems, particularly if patients have come into hospital many times, frequently, it may be worth thinking, okay, well, actually, last time they were sent home without a suction machine. Do we think that a suction machine may help them this time? This is particularly important to think about when patients have a tracheostomy. So, for example, the patients with COPD or bronchiectasis, if they go to intensive care unit, they will often have a tracheostomy, which is a tube in the front of the neck, and that they'll breathe through this tube. So with this, a significant amount of things will need to be organized, a significant number of services will need to be engaged, and if case management can proactively think, okay, we have this patient, he has this problem, and these are the services that he's going to need, and this is the equipment that he's going to need, and then prompt the doctors to say, okay, do you think he's going to need this? Do you think he's going to need that? Shall we request it now? And in that way, we can speed up the entire process. So with this sort of spectrum of conditions that we've just discussed, the healthcare professionals who are involved may be pulmonology, who are the experts in chest diseases, internal medicine and family medicine, nursing services, respiratory educators, dietitians, and as I highlighted, the diet for each specific chronic disease is slightly different. A respiratory therapist will be important to be involved. Physiotherapy is important. Occupational therapy to maybe the patient will need a hospital bed or a frame or a wheelchair. An occupational therapy will need to be engaged to do these prescriptions, and home healthcare will also have to be engaged to follow these patients at home. Diabetes. So diabetes is another very common problem in Saudi Arabia. The incidence varies with age, but the elderly population, over 65, up to 25%. So 1 in 4 of those elderly patients coming into hospital has diabetes. There are 2 different types of diabetes. There's the type 1 diabetes, which affects young people and is only treated with insulin, and the type 2 diabetes, which it can be treated with tablets and affects many more people. And these 2 conditions are responsible for a vast number of complications. The diagnosis is based on blood sugar. Now, this is a very interesting concept, because actually, when I started training, the diagnosis of diabetes was based on a different threshold for blood glucose. It was a fasting glucose of above 7.5. So what happened is they looked at the outcomes of people with diabetes, and they saw, well, actually, the people with a blood glucose of over 7 are getting some complications, not as many as those with above 7.5, but if we reduce the target to above 7, then more people will be diagnosed with diabetes, more people will be treated, and then the health of the population as a whole will increase. So by changing the definition overnight, suddenly a massively increased the number of patients with diabetes and the number of patients who needed treatment. And it affected insurance and driving and many other things that were unintended by this simple change of 0.5 in the definition to that actually makes a big difference to population statistics. And when we talk about hypertension, the same thing has happened in hypertension recently, where they've changed the definition. So when I came to Saudi Arabia, I did not have hypertension, and now, because the definition has changed, my blood pressure is elevated, whereas previously I was completely healthy, and I believe I still am. But these things are relevant when people are concerned and are struggling to understand, okay, yesterday I didn't have hypertension, but today I do. How is this possible? Okay. We also have acceptable targets for patients when they're outpatients, and they're different targets for patients who are in hospital. And when we communicate these things to patients, we need to be very clear that, okay, in hospital we're accepting slightly higher blood sugars for a short period of time, but when you're at home, you need to keep the blood sugar lower. So when we think about diabetes, whilst people are fixated on the number of the sugar, actually an entire program of holistic care is needed. including infectious diseases, kidney specialists, dermatology, GI, maternity care, and neurology, and occupational therapy, physiotherapy, are all needed to provide a holistic framework of care for patients with diabetes, and this requires coordination. And often the case managers can be the linchpin in this coordination by communicating with all of these services, following up and explaining, okay, this person has to do this. This has been done. This is the next stage, and by sort of being engaged in this process, it actually would be would improve the efficiency of the system. So, cholesterol. Cholesterol is another big problem in within this kingdom, and many different problems are associated with high cholesterol. One of which is McDonald's, which is ubiquitous throughout the kingdom. It is everywhere, and burgers and Coke and Pepsi, all of these things contribute to the pandemic of high cholesterol throughout this kingdom. Kidney diseases now. So kidney diseases are basically staged by a single blood test, the creatinine. And on the basis of this blood test, we can see, is the kidney working normally, or is the kidney failing? And many of the things that we're going to discuss all cause kidney disease. So diabetes causes kidney disease, hypertension causes kidney disease, heart disease affects the kidney, and the kidney also affects all of these other things as well. As I keep coming back to the point about the cyclist and the aggregation of marginal gains. A 1% improvement in one system can have huge benefits for the entire body. Okay, so we stage the disease and we say, okay, how much of the kidney is working depending on this stage. So stage 1, kidney is working pretty well, but the patients need to be followed by family medicine initially, and later by kidney specialist nephrologists. But once it gets to stage 5, when less than 15% of the kidney is working, then we need to look after the patients very carefully, because there's a high risk of complications and a high risk of death. And to prevent that, patients can be given dialysis or a kidney transplant. So transplants are still worldwide very uncommon. So the majority of patients with kidney failure are being treated with dialysis. Now, this is again another complicated process which case managers can help engage with, because organizing dialysis is another time-consuming process. But if a patient comes into hospital with kidney failure and is started on dialysis, then that patient needs to have a tube put in for a dialysis line, and then they need to have 3 sessions of dialysis, and then after they've had that, then they can be sent home with dialysis being organized in a dialysis center. So recognizing that this patient is going to be in hospital for approximately 5 days, 3 to 5 days, means that you can anticipate that all the other things that need to be organized can be put into place within that time. So whilst we're trying to optimize the other things, we should try and do it within this expected time frame. So this is cholesterol again. So I'm just going to play a short video now about hypertension.
The heart is the pump in our body.
So that short video illustrated the problems that can occur with high blood pressure. Now, as I said before, high blood pressure can cause kidney disease, and kidney disease can cause high blood pressure. So small improvements in one aspect can actually have huge improvements for the entire system. Now, essentially, these are the new categories for diagnosis of blood pressure, and these have actually been reduced so that now elevated blood pressure is considered 120 to 129. This is a new change which has created a new diagnostic category. So patients who are previously healthy or considered that they were previously healthy are now being labeled as having a disease. That label can be helpful and harmful. So once you have this label, it creates a teachable moment. So the person was asking, one person asked, how would I advise to someone who was who had relapsed after stopping smoking to try and stop smoking again? Well, by presenting to them a picture of how their life could be if they did stop smoking, and saying, okay, which of these people do you want to be? Do you want to be someone who's in and out of hospital with COPD, or do you want to be someone who is fit, healthy, can do all the things that you want to do with normal blood pressure, and so on and so forth, and motivating people and finding out what matters to them is how we can engage people to initiate a sustainable change. And ultimately, it's up to that individual, but we can offer sensible advice. Now, when we spoke about the healthy lifestyle and the unhealthy lifestyle, many of those things are directly relevant to hypertension. Weight loss, an appropriate diet, reducing salt, exercise, all of these things are a healthy lifestyle and are relevant to patients with chronic diseases and preventing chronic diseases. So if the heart actually fails, we call that situation heart failure. So where the heart hasn't quite failed, but it's actually struggling to cope with the situation. And this is a very, very common reason for patients to come into hospital. And I'm just going to go through an improvement project that we undertook to actually try and reduce the patients' admissions and readmissions due to heart failure, and highlight the role of case management in facilitating that improvement project. So when we think about heart failure, it is a general decline in patients' ability to breathe and move because the heart isn't pumping it effectively. And that general decline is punctuated by sudden deteriorations when patients come into hospital. And each time a patient comes into hospital with heart failure, the chance of them dying earlier is increased. So keeping them healthy and outside of hospital is good for the patient, and it also reduces the costs of healthcare. So who are the health professionals involved in this process? Cardiology is involved, endocrinology, internal medicine, family medicine, nursing, home healthcare, cardiac nurse specialists, diabetes educators, dietitians, the respiratory therapists, the physiotherapists and occupational therapists, and the case management to coordinate the whole process are involved in the management of patients with heart failure. So when we think about the risk of patients having heart attacks or developing heart failure, we have various calculators that will help us to calculate that risk. And so they will give us a pictorial view of, okay, over the next 10 years, your risk of having a heart attack is very low. So this can actually guide doctors in thinking about the treatment that patients should be offered and the lifestyle changes that patients need. Now, what I wanted to talk about is risk stratification for case managers when they are assessing their caseload and thinking about how much intervention and support each patient is going to need, so they can prioritize the workload. So what we want to do is stratify patients into broad categories of high risk of needing a lot of help, medium risk they'll need some help, and low risk they probably will not need much help. Okay, and when we talk about risk, it refers to the clinical risk, the likelihood of the patients having a bad clinical outcome. Sometimes it will be very clear to you that, okay, a patient with rheumatoid arthritis will cause more complications than osteoarthritis. Osteoarthritis is just wear and tear of the bones and joints, and rheumatoid arthritis is an active inflammatory condition. Other times, you'll get a gut instinct. You'll say, you know what, I'm worried about this patient. I think that I need to spend some more time with them. So what I recommend is that you use objective data from the patient's healthcare records, plus your subjective clues and your feelings to actually help and define this risk. And remember, this is a dynamic process that needs to be reevaluated as the patient's status changes and care needs increase or decrease. Okay, so if we look at the health record data, I'd like you to think about the chronic conditions the patient has, the age of the patient, their comorbidities, their physical limitations, whether they have a high or low health literacy, whether they've been in and out of hospital multiple times, or whether they've had recent major surgery or they've injured their head recently, whether they're on a lot of medications, and whether they have difficulty following a treatment plan. Okay? So if they have, one of these categories, you could say that they were probably medium risk. If they have two or more, they're probably high risk. Okay, but the subjective things that, okay, for a patient who is otherwise has no other chronic medical problems, are their biometrics, their weight, is it in or out of range, blood sugars, are they having chronic conditions, but are they well, or are their chronic conditions uncontrolled? So these things are going to adjust your concept of the risk of that patient having complications. And so the patients who are more likely to have risk, you need to prioritize. There are some other soft markers that you can feed into your assessment of risk, and that includes the patient's housing, their diet, their transportation, their financial sort of reserves, their level of education, their employment, and all of these things will feed into your overall assessment of the risk of that patient having complications. Once you've actually worked out, okay, these are the issues the patient has, you can classify them into high to low risk of dying or being or remaining in hospital for a long time, or low risk. Okay. Now, and this slide just illustrates the difference in the level of input that patients are going to need depending on this risk stratification. So at level 1, what we're talking about is keep well care. We want to prevent disease, organize immunization, arrange annual health checkups. Okay, and the number of health professionals involved is relatively few. But patients who are at the higher end of the spectrum, where the risk is higher, they need much more input and many more health professionals. So coordination is going to be much more important and relevant. So risk stratification in this way will help you sort of think about and manage your caseload and actually prioritize interventions to those who need it most. Okay. So the next question is, how can we reduce patient risk? So we need to do discharge planning almost from the day that the patient comes in. And you need to report any changes that occur in the patient care plan that cannot be resolved immediately. We need to educate patients and encourage self-management. And medication reconciliation is an important process for medication safety that I've been asked to talk to you about. So I'll cover that briefly as well. So coming on to discharge planning. As I said, I was going to tell you about the sort of the project to reduce length of stay for patients with heart failure and reduce readmissions. And essentially, Dr. Mohammed Al-Qahtani, the chairman of Bed Management now, came up with this pre-discharge checklist of things that should happen for every patient with heart failure before they are discharged home. In parallel to this, we did a process map of the pathway that a patient follows after admission to hospital with systolic heart failure. And in order to expedite the process, we engaged nursing and pharmacy and nutrition and case management to support this process. Okay, so going through this, there was an important medical component that the doctors dealt with, but whilst that was going on, the patient received a substantial amount of education about reducing their risk factors, taking their treatment, how to monitor their own heart failure, and stopping smoking. Nutritionists saw them, and they had a cardiac rehabilitation appointment, and follow-up was organized and arranged. Okay, so now, when should changes in the patient's care plan be reported? If there is any change in the patient's condition, this should be escalated to the physicians immediately, unless it can be resolved very simply and quickly. So anything that changes should be highlighted unless it can be resolved. So, for example, if the patient needs some equipment and this equipment is not available, then the physician should be informed, because actually he may be able to think of an alternative strategy or an approach that may solve the problem. It may not be as good as the initial plan, but it may serve the purpose. But if we leave things to the next day, the patient may deteriorate, or the patient may not be discharged home and may stay in hospital longer. So all changes in care plans that cannot be resolved rapidly and effectively need to be escalated. Okay. Patient education and self-management. So we need to engage patients. Why is patient self-management and education important? So that highlights it's a very amusing video, but this still happens in real life. The patients have not been educated in how to use inhalers properly, and this is a common cause of admission to hospital due to failure of treatment of asthma at home. Now, patients need written or pictorial information to help them remember and plan and monitor their self-management. And we need to give them a written summary to take home with them. So we need to give them some sort of self-monitoring tools such as calendars or charts. And then we need to encourage them to use them by looking at them when the patients come into hospital. So this is an excellent example of a case of a patient information leaflet that again was developed by Dr. Kathani from the bed management department. Now, this document basically highlights in English and Arabic what patients should do to help themselves control their heart failure. And this is an example of the self-management plan that they were given, where they were asked to weigh themselves and with clear targets for their weight and how many tablets of furosemide to take if their weight changed. So this is a very, very clear patient self-management plan that actually can help reduce admissions, readmissions due to heart failure. Now, that's what's available now, and in the future, many other things are possible. So it may be possible for this to be done with remote monitoring, with the patients at home, having a nurse specialist take telephone calls from patients who have questions about what they should do. And in the 21st century, we say an apple a day can keep the doctor away, but this is the apple that we're talking about, because app-based healthcare is the future of medicine, and engaging with this through advances in monitoring and patient self-management will actually give patients control of their health. And as physicians and case managers, our responsibility is to be aware of what is available for patients and encourage them and educate them in how to use the 21st century technology that's out there. Okay, and this is evidence-based data showing that application-based healthcare for heart failure is actually cost-effective and reduces admissions to hospital and is preferable to patients. Okay, substantial evidence for cost-saving measures from these potential interventions. So, coming on to medication reconciliation. Now, this is a very, very, very important topic, and it is a problem that is a significant cause of medical errors and delays discharge. So, engagement of case management in the process of medication reconciliation will actually substantially improve patient outcomes. So what is medication reconciliation? It is comparing the medications a patient is taking and should be taking with the medications that are needed when the patients come into hospital. You get rid of duplications, omissions, and interactions, and be certain what patients need to be taking when they are actually in hospital. Many, many times I've reviewed patients the day after they come into hospital, and the relative hands me a box of different medications that the patient should be taking, but are not put into our system. And the challenge that we have is that the patients are often looked after in multiple different healthcare systems within Riyadh, or even coming from outside Riyadh, and so we don't have the fully active medication list within our electronic healthcare record. So and for some reason, even though we will ask patients in our daily rounds, they don't remember until the other son who's coming, who actually looks after the patient, brings the box of tablets into the hospital. So if you become aware that the patient relatives think some medications are missing, please highlight this. This is very important to tell doctors about. So, because we need to have a very accurate list of what medications the patients need, and we need to be very clear about which drug it is, why they're taking it, the dose, how often they should take it, and are they taking it as tablets or liquids, or how are they actually taking it? And when we admit the patient, transfer them to another service, or discharge the patient, we need to be clear that this is the most correct list. And our aim is to provide the correct medications to all patients at all times. And the real challenge is that if on the day of discharge, the patient's relative says, well, what about this tablet? We haven't, you didn't give it to us. If we then have to add it to a patient's list of discharge medications, it can delay the discharge by several hours, because that new medication has to be sent to the pharmacy. The pharmacy have to prepare this and then send it back to the floor. But this, the pharmacy may take several hours to do this. And in the situation where with bed crisis and patients boarding in the emergency department, these 2 hours can cause significant problems for many patients, not just the patient who's waiting for the tablets. Okay. So this is a top patient safety priority, and it should be considered every time the patient transitions from one care point to another. And it is a very important strategy for preventing harm from medications. So what needs to be done? We need a list of all the patient's current medications. And actually, we need to know which ones the patient is taking. Sometimes the patient's relatives bring a box, but actually the patient isn't taking them. So we need to be clear which ones the patients are actually taking. We then need to list all the medications that the patient needs now, and then compare the lists and make a new list that is best for the patient right now. And we need to agree that with the patients and their carers, because many times I find that, okay, patients have been sneakily giving, relatives have been sneakily giving their relatives who are patients in hospital tablets from home, and we find out about it later. And this is either doubling tablets, or there may be some interaction with the medications that we're giving, and so this can cause significant problems and harm. Okay, so medication reconciliation is a very important part of this process. Okay, so I'm just going to illustrate what this process sort of looks like. So this is one patient who was admitted under my care, who had a liver transplant, and they had lots of chest infections, and 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16 medications that they were taking at home. So when we saw them, we stopped as many as we possibly could. We then added a couple of new medications just for the duration of the hospital stay, and this is the new medication list. And when the patient is discharged, we'll remove the patient medications that are only needed during the acute admission, and give them a new list of medications that will essentially only be 1, 2, 3, 4, 5, 6, 7, 8. So we've gone from 13 medications to 8 medications, which is very important to consider, because Benjamin Franklin said the best doctor gives the least medications. But in our culture, people want tablets. So educating patients that actually, you know what, it's better to take less tablets, it means that they will actually listen to what we tell them. Because unfortunately, in this place, we need to recognize the cultural beliefs about healthcare and manage those expectations. Because if we stop the medications but don't educate the patient, then they will continue to take them at home, and this can cause harm. Now, someone has said, but we can order the medications one day before. This is absolutely correct. We can order the medications one day before, but what will happen is when the patient's relatives or the patient receives those medications, then they'll realize, actually, you know what, you didn't give us this medication. So if that new medication is added the next day, that will still cause the delay of several hours. So this is why doing the medication reconciliation prevents delays, because with the best will in the world, I have constantly been asking patients, okay, what medications do you have? But it's not until the day of discharge. We already prepared we already scheduled the discharge the day before, ordered the medications the day before, but on the day of a discharge, the patient's relative says, we need this medication as well. And that builds in the delays. Okay. So in conclusion, what we've talked about for this presentation is keep well chronic care. We've discussed chronic diseases in Saudi Arabia. We've discussed the basics of chronic diseases and risk stratification, and we've also talked about medication and reconciliation. So thank you very much for listening, and I hope you've enjoyed the few hours that we've spent together today, and I hope you've learned a lot that will be helpful as you move forward as case management. And I would be very grateful for any feedback that you have about the content of the lectures, and if you think that anything else needs to be covered that would be relevant to the medical knowledge of case managers in Saudi Arabia. Thank you very, very much. And if there are any brief questions, then I can take them now.